In today's lecture series on radiology, we'll talk about acute shoulder syndrome or acute shoulder pain. It's synonymous to impingement syndrome. In impingement syndrome, there is usually a structure specifically anatomical, like the acromion, which is either hooked or it's lower inferior surface is impinging the structures that are beneath the acromion, and due to which when overhead activities are performed, like brushing the hair or dressing oneself, there is acute pain. So if the acute pain is due to overhead activities, then a conservative treatment is suggestive of that. But if there is night pains and if there is acute, very severe pain in resting positions of the arm, then it is suggested that one should look for surgical interventions. So let's get to it. So first, to discuss the radio or to interpret radiographs, we must know the anatomy of the shoulder, the joint, the glenohumeral joint, and the other joints like AC, acromioclavicular joint. Or we have to know certain anatomical structures like the coracoid process. We have to know what is the attachment of the tendons. For example, the rotator cuffs are attached or inserted to the greater tubercle of the humerus. So let's look at the anatomy. So this is the chest and the upper extremities. So this is the clavicle, acromion, coracoid process, scapula, humerus, and this is the glenohumeral joint. This is the glenoid cavity which contains labrum, and this is the humeral head. So all of this is what we call the shoulder joint. Also, this is also included. So let's move forward. So this is the clavicle. Like I said, this is the scapula, or this is actually the acromion, and this entire is the scapula. This is the humerus, the scapular acromion or the acromion process, the coracoid process, the greater tubercle of humerus, which is an insertion point for the rotator cuff tendons, humeral head, humeral lesser tubercle. Now let's talk about what acute pain and trauma, how to actually diagnose shoulder syndromes or shoulder pain, how to reach a diagnosis. So the diagnosis of any shoulder pain or syndrome or any trauma, after a trauma, if a patient presents with a very severe pain, how to diagnose it and know if it's acute impingement syndrome. So acute impingement syndrome will be diagnosed on the basis of the history, the mechanism of the injury, the physical exam, which includes exams or the tests, physical tests like the near impingement test, which we will talk about, and then radiographs, which include the MRI, the CT scans, and obviously the first will be X-rays. So in the physical exam, like I said, Near's impingement test is used, which is a test in which the individual is asked. First, you have to actually counsel the individual that there is going to be pain associated with this test if there is a rotator cuff injury. So what is asked of the patient is that they internally rotate their arm, and then they raise it towards the roof. If obviously, because the space between the humeral head and the acromion process decreases, so if there is an impingement there, or a cuff tear or rupture, then it will result in severe pain. And if there is a very severe pain, NSAID can be given, or an intramuscular injection, or an bursa injection can be given. Xylocaine is normally used for that. So this is how the orientation in which a patient is asked to sit or stand or lie for an X-ray. So this is the X-rays coming from this direction, and this is for the patient who is standing, and this is for the person who is lying. So they have to rotate themselves 45 degrees within X-ray oriented in this direction. So we will talk about this in the coming slides as well. So this is the orientation. We either orient the bucky or the cassette in a 45 degrees angle, or we ask the patient to tilt themselves in a 45-degree angle, and the X-rays are in this direction oriented. The X-ray tube is oriented in this direction. This is the view that we get. So this is actually to visualize the glenohumeral joint in which there is no overlapping. This is called Gracie view, or the Gracie view. It's Grasey. So there are different pronunciations. So this is actually to visualize this gap. So, and this is how the patient is oriented for this view. So this is normally 9 to 10 millimeters. And if there is any increase or decrease here in this normal distance, then the pathology can be diagnosed. So this is 9 to 10 is normal. If there is less, then obviously narrowing of the joint space is a characteristic of arthritis, or it can be due to some compression injury. If there is sclerosis of these joints, then obviously that is also indicative of joint disease. So this is how you visualize this joint, and you use the Gracie view, or the Gracie view. This is the Y view of the shoulder joint. How you do this is this is internally rotated humerus. As you can see, this is backward. The humeral head is facing posteriorly. So this is internally rotated arm, and the patient placement is such that the face is away from the tube of the X-ray machine, right? So the X-rays are coming from the posterior side, and the bucky is here, and the patient is placed in this orientation. So the 45-degree tilt, and the bucky is in front of the patient, so it's a posterior lateral view. So this is the orientation in which this view is taken, and the shoulder is internally rotated. The hand can also be placed on the hip, and that will give a better visualization, and a better Y view. But in this radiograph specifically, this humerus is internally rotated. So this is a normal radiograph. We are right now just talking about the views, different views to visualize the joints and the entire shoulder anatomy. How does it appear on radiographs in different views? That's what we were talking about. So this is the anterior posterior view, or the AP view. So this is the glenohumeral joint, clavicle, acromion, coracoacromial joint, or the AC joint, the humerus, and these are the ribs. So shoulder trauma, and this is the Y view. This is how you take the Y view. So if the patient is oriented in this direction, either the patient will be tilted 45 degrees, or the bucky can be placed at a 45-degree angle. It's up to the person or the technician who's taking the radiograph. So this is the tube of the X-rays, and this is the orientation, and this orientation will give you a Y view. Okay, so this is the axial view. Axial view, this is again normal X-ray. So this is how it is taken. So this is the axial view with the humeral head, the coracoid process, glenoid, and acromion. So clavicle is not very well visualized in this axial view. So now we have this normal Y view. Like I said, Y view can be anterior posterior and posterior anterior. Some people take it while the patient is standing facing the X-ray tube, and some people prefer it taking when the patient is facing the Bucky or the X-ray cassette. So, but the here this before the humerus was internally rotated. Here it is suggesting this x-ray view that the hand is actually placed rather on the hip like this, or maybe just normally placed, not internally rotated, just normally placed. So this is a view taken from anterior side. So this is an AP view with the patient oriented at 45 degrees. And this is showing, this circle is showing the glenoid cavity, this humeral head, which is backward because this is the orientation in which it is taken, like this, and this is how the x-ray tube is placed, and the Bucky is behind. Okay, so this is the acromion, the coracoid, glenoid, and humeral head. These are the ribs and the clavicle, and the manubrium sterni is not visible here, but it should be visible. So this is another AP view. This is showing the dislocation of the glenohumeral or the humeral head, we call it, the dislocation of humeral head. It is anterior inferior dislocation, and it is the most common dislocation at the shoulder joint, the anterior inferior dislocation. So this is anteriorly placed and inferiorly placed. We will talk about what happens even after the reduction and the proper placement of this humeral head, even when it has returned to its anatomical position. There are certain things that should be kept in mind, like we're going to talk about the Hill-Sachs lesion and what happens to the inferior surface of the glenoid labrum. We will talk about that later. So this here is to identify the dislocation of the humerus, which is the inferior anterior dislocation. This is an AP view showing the clavicle, the acromion, the scapula. This is the entire scapula here. This is the spine of scapula, acromion, coracoid process, clavicle, and the glenoid cavity. This is the glenoid cavity, and this is the humeral head displaced interior inferiorly. So now we're going to talk about the MRI. So MRI, this is the subscapularis tendon. This is the glenoid cavity, the labrum. This is the humeral head. So what is T2 MRI? It's a type of MRI. It's T1, T2, fat suppression. So these are the types of MRI. So this is T2. What is indicating that this is T2 is that the fluid in T2 appears hypo intense or black. So there are certain terms that we use. The hypo intense means black, hyper intense means white, and in T2 fluid appears hypo intense, bone appears intermediate, the cortical bone appears hypo intense. So the fluid will appear hyper, so it'll appear white in T2. And the bone, the cortical bone, will appear hypo, which means it'll appear black in T2. So this cortical bone is these margins. The bone margins are the cortical bone, which is black, so it's T2, and this is the subscapularis tendon. And here, this we can see is a rupture of this tendon, the bursa, and on top of this is the rupture. So Bankart fracture, this is what I was talking about earlier. So this is the dislocation. So this is again an anterior-inferior dislocation of the humeral head. And this is the orientation of the glenoid, the anatomical. There is nothing wrong with this glenoid cavity, only the humeral head has been displaced due to any trauma or maybe some injury. So what is happening here is that when it is reduced or is placed back in its anatomical position, the humeral head, when it is reduced, what happens is that this fracture is to be noted. This is the Bankart fracture. What happens is the Bankart fracture is actually the inferior labrum, glenoid labrum fracture. Because of the dislocation, two surfaces are vulnerable to fracture. One is this surface, the inferior labrum of the glenoid, which can be fractured due to a dislocation, and the other is this portion, the superior portion of the glenoid. So when the fracture of this portion results, because it is in a close proximity to the glenoid, so it is normally seen with dislocations that this portion is fractured or this portion of the glenoid cavity is fractured. This is the superior posterior surface of the glenoid. So the fracture of this surface is called Hill-Sachs fracture. We'll talk about that later, but it should be noted that it's because of this dislocation that these two fractures result, the Bankart fracture and the Hill-Sachs fracture. So Hill-Sachs is a fracture of the humeral head, and the Bankart fracture is actually a fracture of the glenoid labrum. So humeral shaft fracture. So this is very apparent. So this is a through and through shaft fracture of the humerus. So this is probably the bone of a child, because this is a growth plate is present and the complete ossification of bone is not apparent here. So this again is a spiral oblique fracture of the humeral shaft. So now we will talk about the clavicle. So this is the AP view. This is the clavicle. It's a comminuted fracture, and this is the acromion, the humeral head, the glenoid cavity, the scapula here, the spine, and the spinous processes of the vertebral bodies. And these are the vertebral bodies. So this is a comminuted fracture, and there is a visual increase in the AC joint space as well. So the normal is 7 for males and 6 for females. So this is looking to be more than normal, but it has to be measured for a conclusive diagnosis. But there is a comminuted fracture. And this is the surgical reduction, or this is how it's reduced, or this is the open reduction. So open reduction means it's surgical. So closed reduction means that dislocations are placed in anatomical, bones are placed in anatomical positions without any surgical intervention. So this is the screws, and a wire could not be placed here because of so many fragments. So screws were adjusted. This again is a clavicular fracture. So this is an AP view. This is the humeral head, the acromion, coracoid process, glenoid. This is the glenoid cavity, and this acromion, this clavicle is again comminuted fracture. So this degree cephalic turn is the head, which is turned, so that's not visible, but that's nothing unusual. It's just an AP view, that's it. So the 45-degree cephalic tilt is because this is how the head is tilted for a better view. So this is what I was talking about, the AC joint. There is a normal space between the acromion and the acromion and the clavicle, which is 7 mm for males and 6 mm for females. And any reduction or increase in this space is obviously suggestive of some disease. So this is weight bearing. And obviously if there is any shoulder pain, and if you're taking weight-bearing x-rays, then it should be counseled to the individual that they're going to experience very sharp pain, and it's suggestive that you keep a steroid injection or a xylocaine injection ready for such a patient. So weight bearing, and also you should adjust or you should position the patient. You should adjust everything before handing the weights to the patient, so that that's the last of the entire procedure, so that there is minimum further damage to the joint. So this is what I was talking about. 7 mm is the normal space between the acromion and the clavicle in the AC joint. And 6 mm is the normal for women. So rotator cuff injury. So these are the 3 sequences of MRI. So rotator cuff is 4 muscles: the supraspinatus, the infraspinatus, teres minor, and subscapularis. So the injury to any of these muscles result in rotator cuff injury. The overhead activities are limited. There is sharp pain on any overhead movement, or if it's an advanced condition, there is pain on any shoulder movement. And if there is night pains are suggestive that the tendons are probably ruptured, and a surgical intervention is prescribed or thought of in conditions with night pains. So this is the T2 sequence. Then we have the fat-SAT sequence, or the fat suppression sequence, and then we have T1. So we talked about T2. What happens in T2 is the cortical bone, like is visible here, is hypo-intense, which is it's black. The cortical bone here is visibly black, so the rest of the bone is intermediate at places where the density of the bone is not very high, and the rest of the places are hyper intense, which is white. So the fat in T2 is also hyper intense, which means it's white. The fluid in T2 is hyper intense, so that means it's white. So this is the supraspinatus tendon, passes here, and this also is the supraspinatus tendon coming here, this one, and this is the subscapularis tendon. So here also we have the subscapularis tendon, and this here is the supraspinatus tendon. So all of them are attached to this greater tubercle of the humerus, as visible here. So this is a tear in the supraspinatus tendon. It's a complete rupture, as is visible in the fat-SAT as well. So, and here, this is the rupture. So in T1, what happens is that in T1, the fluid is hypo, which means it's black, as contrary to T2, in which the fluid is hyper, which means it's white. And the fat in both the sequences is hyper intense, which means it's white. So that's why we use this fat suppression sequence to suppress the fat, so that this entire fat is no longer white here, see? So the fat has been suppressed, and there is better visualization of this tendon, and we can see that it's ruptured, and there's some very little bleed in proximity to this rupture. So that is rotator cuff rupture. This is a complete rupture. So this is, now we move to the scapular fractures. This is an AP view. This is the entire scapula. This is the glenoid cavity, the acromion, the coracoid process, and here this is a fracture, and then here, this is a fracture line going this entire area, going up to almost touching this fracture. So, and this is the fracture here of the inferior anterior labrum, which is also called Bankart fracture. So this fragment has been dislodged here. So it's a dislodged fragment of the labrum. It's probably dislodged from this position here. So these are the 3 sites of fracture of the scapula. So this is what we were talking about. This is the Gaucher view or the Gaucher view. So this is, we can see the sclerosis of the glenoid cavity, and also the labrum is present, which is not visible here. So this is a little bit of sclerosis, and this is the joint space. So in Gaucher view, we can visualize the entire humeral head and the glenoid cavity without any overlapping. And in any other sequence, in any other position, there is always overlapping of the glenoid and the humerus. Sometimes the glenoid is present right in the center of the humerus head, like we saw in the Y view. It's actually in the middle, right in the middle in Y view. So in Gaucher view or the Gaucher view, it's we can see this space, which we talked about is normally 7 mm for males and 6 mm for females. So this is Gaucher view. So again, this is scapular fracture, and for which this Y view has been taken. Like I said, Y view can be taken in multiple positions. We saw a Y view taken in internal rotation. We saw a Y view taken in normal arm position or normal hand position. But this here is probably a position in which the in which the arm and the forearm is placed in this way here, or it's this way. So this is the humeral head, and because of the placement of the arm, the glenoid cavity is not in the center, but the Y is very visible. So there is decreased bone density of the clavicle, the acromion process, and the blade. This is the blade of the scapula. So, and this is the humeral head. So it's a fracture here. It's a fracture here. So this is the fracture of the humeral of the scapula. It's not humerus or the glenoid. It's actually because of the overlapping, but this is where the fracture is present. So the blade can be seen as there is sclerosis of the blade as well. There is this decrease in this bone density here and here. So this is probably somebody who's old and somebody who has decreased bone density. So there is this is suggesting, because the space is these are actually overlapping, it's because of the placement as well, but it's suggesting that this individual has some joint disease, but there's also fracture here. So now the humerus. This is the humerus and the anatomical neck, excuse me. So the anatomical neck is present right next to where the head is joined with the shaft. So this is the anatomical head. There is a little bit of depression here and here, and it's suggestive of an anatomical head, and we call it the neck of humerus. So this is the humerus, the glenoid cavity, the acromion, the clavicle. This is the spine of scapula coming here, and then the acromion here. And this is the scapula. These are overlapping, the spine and the clavicle are overlapping, but this is to be viewed very carefully. So this humeral head is completely separated from the entire rest of the shaft of the humerus, right? So there is associated swelling. So swelling is can be seen on an X-ray. So there is associated swelling everywhere here. This is the reason why there is some attenuation, hyperattenuation here. So this entire anatomical neck of the humerus is fractured. Now we talk about the surgical neck. So surgical neck is behind or below the anatomical neck. This is the anatomical neck here. and this is the surgical neck. So surgical neck is this actually. This is the surgical neck. Surgical neck is beneath or right below the greater tubercle of humerus, and it is above the deltoid tuberosity. So deltoid tuberosity is beneath this surgical neck, and the greater and the lesser tubercles of the humerus are above this surgical neck. So this is a fracture of the surgical neck here. This is a comminuted fracture. The humerus head and the associated piece of shaft is displaced posteriorly, and this is the rest of the shaft is placed anteriorly. It's displaced here, and it's a complete fracture, and there are fragments associated with this fracture. This is a fragment here. This is an irregular fracture, and this is a fragment right here. So shoulder dislocation. So this is an anterior and inferior. So normally anterior dislocation is always accompanied by inferior dislocation as well. So anterior is not just isolated. It's always with an inferior directed displacement as well. So this is an anterior or anterior-inferior dislocation of the humeral head. This is the glenoid cavity, the coracoid, the acromion, the clavicle. So this is the MRI, and we can see here the posterior labrum, the posterior labrum here, the humeral head here, and it's displaced anteriorly. So it should be here, here, and it's actually here. So this is how it will be seen in an axial view taken from above, and it's sliced way. So this is the posterior dislocation, in which we can see the head has completely rotated on itself and it's placed posteriorly, so it's no longer in conjunction or in close or is in this glenoid cavity. So it's completely rotated, and it's behind, it's facing posteriorly. So this is again clavicle, acromion, glenoid cavity is and the humeral head are completely isolated from one another. This was an AP view, and this is a lateral view, or it is actually a lateral. So actually the Y view is also called a lateral view. So this is a Y view, the glenoid cavity, the coracoid, the acromion, and this is the humeral head here facing posteriorly. So it's a posterior shoulder dislocation. Not as common as the anterior-inferior dislocation, but it is seen. So Hill-Sachs lesion. We talked about this. This area is vulnerable to fractures in cases of dislocation, anterior, posterior, anterior, inferior dislocations. This area and this area, the labrum, are always vulnerable to fractures in dislocation. So if the labrum of the glenoid is fractured, it's called Bankart, and if this surface of the humerus is, or the humeral head is fractured, it's called Hill-Sachs fracture, so, or the Hill-Sachs lesion. So what is the surface? It's actually the superior posterior surface of humerus, which is vulnerable here because of this dislocation. So now we move to the clavicular fractures. We saw some of the clavicular fractures before as well. The comminuted fracture, which was surgically corrected with screws. So this is again a distal clavicular fracture, which is displaced superiorly here. This again is a clavicular fracture, acromion clavicle. So it's separated completely. It's an irregular fracture site here, as we can see, but there are no fragments seen or we need more views to actually rule out if there are any fragments. So it's very important to have multiple views of the similar fracture site to diagnose better. But here it seems that this is an irregular fracture with no dislodged fragments. So it's a clavicular fracture here. So here also it's a comminuted fracture here because there are fragments. I think this is a fragment, and this is placed superiorly, and these are 3 fragments, so one, the second and third. So it's comminuted fracture. This appears to be a little bit wider than normal, so it has to be measured for a correct diagnosis. Okay, so we talked about this. This is obviously more than normal. This is usually it should be here. Roughly, it should be here for a normal, for indicating a normal joint space. But this is obviously more than 7 for male or 6 for females. So acute rotator cuff tears. So in acute conditions, there is obviously a bleed. So this is a bleed and a rupture of the subscapularis tendon here. Also, it can be seen here that there is swelling, there is rupture, and there is bleed. So that was the end of today's lecture, and today we discussed the shoulder anatomy. We started with the anatomy of shoulder. We then discussed the how normally shoulder region appears on x-rays. We discussed different fractures of different sites in the shoulder region. We also discussed the dislocation. We talked about different anatomical variations associated with fractures, and that was it for today. I hope you liked it. And to watch more videos on medical subjects, please visit sqadia.com. So there are numerous lectures available on the site, and that's it. Thank you for watching.